Thank you very much for the invitation. I'm very happy to be here. I don't know if it's a problem. I'm being invited to talk about complications, but I'm going to do the task. I'm going to talk about recurrences and complications of any AC joint surgery and what do we do to consider optimizing the results. These are my disclosures. So I'm going to talk about what can happen after distal clavicle resection and what can happen after acromioclavicular reconstruction. I think this is being covered in the next talk as well, but just very shortly, most studies, even in meta-analysis, shows a pretty good success rate of distal clavicle resection. It's about 10% failure, but I think only the failures are mentioned here, not the disasters. What we should be aware of is the insertion of the AC ligament. The superior AC ligament is inserted from 3 to 5.3 millimeters in the acromion, and the inferior ligament from 2.4 to 4 millimeters. So it's very close. So when you look at these figures, you can see if you resect more than a centimeter, even more than 7 millimeters of the distal clavicle, then you end up with a too big resection that may end up in horizontal instability. So this is the safe resection, so very conservative. Nothing happens. Okay, so this is a patient coming into my clinic many years ago. He had a small AC distortion. He had the first distal clavicle resection didn't help. He had the second one, and then the third one ended up with this. And that day, it's many years ago, I think. Oh, it's okay. A lot of things went wrong that day. They didn't have the right screws on the OR, and I couldn't go around the coracoid because I didn't have a Deschamps. But actually, he's one of my most happy patients. I passed the graft around the coracoid, and the interference group held. So he became horizontal stable, and this is what I call sequential clavicle amputation. This is not a good idea. This is an example, and it's not as bad as the other one. No, I need the videos to run. This one. This is a woman that had open distal clavicle resection. This is her active range of movement. So this is what happens when you resect too much. Please note, actually you can see there's a groove here. So this is her activity. She's in pain and she cannot move this arm. So as I said before, I use this Rushton technique. I modified a little bit. This is 8 weeks after operation. So just by putting in a graft and reinforce it with a fiber tape, you see here it's deep groove, it's horizontal unstable. This is what you see very fast after the operation. So this is one of the problems of resecting too much of the distal clavicle end. So just to conclude, this is that the most commonly failure is from this procedure is horizontal instability after excessive excision, and this is more than 10 minutes, maybe even less than that. And I think it's a good option to do an augmented free tendon graft. It's simple and has a high success rate. So then I'm going to talk about what can happen and what can go wrong after AC joint reconstruction. There can be many reasons for this. It can be technical failures. It can be failures of restrictions, lack of compliance. Recently I had a failure from physiotherapy, too much manipulation within the first 2 or 3 weeks. These are some of the many technical failures that can happen. Surgery can be dangerous. Actually, you can malposition the tunnel, you can fracture the tunnel, you get too tight or too loose repair, you get weak repair, augmentation, especially when used only suture anchors. I think this is not being used anymore. AC ligament not addressed, just like Frank said, and as we also discussed before, the delta trapezial fascia is very often not only in grade 5, but in many cases it needs to be repaired. And there are many reasons for this. So a lot of things can go wrong during the surgery. And then actually failure restrictions. Some patients are too eager. They want to move the arm right away and they can do that, but not over 90 degrees. Some of them are a little bit clumsy. They fall again. And then some physiotherapists think it's very wise to do very heavy loading within the first 6 weeks, which I'm not a fan of. And then I had the patient recently that had a very severe manipulation 2 weeks after the operation, and everything was broken up again. So if you look at this insurance database study, it's not very high failure rates, but they looked at who were the patients that got the complications. It was only over 35 years. It was mostly frozen shoulders or revisions. Over 50 were more commonly the infections. And then females were more likely to have a new revision, reconstruction, or a distal clavicle resection. This is a systematic review. The overall failure rate here was nearly 21%, and the complication rate was 14%. And infection was the most common, and then a fracture of the coracoid. It's a serious complication, I think. And then you have failures of the hardware as well. And they concluded that there was no significant difference between arthroscopic and open techniques, and open surgery had a greater rate of clavicular or coracoid fractures than arthroscopic surgery. This is a scoping review from Diana et al. Showing the complications rate actually varied between 5 and up to 89%, really dangerous surgery. The evidence for treatment of revision is still lacking. They suggested that you should restore the native joint biomechanics in order to get the best results. This is some numbers taken for this paper. This is a paper by Spencer, 154 patients. You see very high complication rates, and this is the preferred technique with a combined allograft loop and a synthetic cortical button fixation. But all these very high complication rates. And another one with 1,450 patients, a meta-analysis with very high complications rate for nearly all procedures. These are some slides I bought from Frank, because we know there's so many studies out there showing that there can be problems with the tunnels, not only with the dog bone or other devices, also with the drilling tunnels for the open anatomic reconstruction. Hook plate and other hardware, I think it's been mentioned before. You get nice x-rays, you get a reduction, but you also get a high recurrence rate. You need a second operation. And if you look at the meta-analysis and randomized studies, there's no advantage over even non-specified, non-operative treatment. I think it's old techniques that had higher failure rate, and you get very often recurrent instability. Then the last part of my talk is going to talk what should we do to optimize the result. I think the very most important one is the careful selection of the patients. I think it's been mentioned sometimes now. A lot of patients don't even have that many symptoms, so you should really pick the right patients. You should use your own safe method, and I think you should respect there's a learning curve for nearly all techniques. You need a lot of volume and training. And I think you get wise. We get wiser by reading the literature, but even wiser by following our patients. And you should also remind yourself that the postoperative X-ray is not the final result. I have colleagues in Denmark that never see the patients after surgery, and I think that's where you learn the most. Patient compliance is important, and as I said, I have sometimes problems with some physiotherapies that are a little too aggressive. So Diana et al., they suggested these. If you have technical problems here, you should use an anatomic reconstruction with a CC and AC ligament with a free tendon graft. And whereas if the problem is a persistent horizontal instability, you should use an anatomic reconstruction of the AC ligament also with a free tendon graft. But this is low evidence. And we always talk about anatomic reconstructions. This is some pictures I bought from Gosma Soga. And you see that the ligament, the conoid ligament, is actually a fan-shaped ligament, and we don't have a fan-shaped graft right now. This may also mean something with the rotatory stability. So we don't have the right, I think, complete anatomic reconstruction method. So the attempted anatomic reconstruction is to augment the two CC ligaments and also address the AC ligaments and remember the fascia. If it's broken, fix it. And then you can do this arthroscopically, or you could do it open with a free tendon graft. I use this method for more than 12 years now, and I think it works very well in the chronic cases. Use the remnant here to address the AC joint, the horizontal instability. But of course, there are some technical challenges. Nobody's perfect. We discussed this before, when you use an autograft, you have a risk of donor site mobility. We had up to 43% at a half a year after the operation. We reduced this to 12% after we changed the post-operative rehab protocol, focusing on hamstring rehab. And then when you pass the graft around coracoid, we had some fractures as well, nerve damages, temporary nerve damages because of the close connection to the brachial plexus. So a lot of things can go wrong. when you move to the clavicle, of course, with the clavicle tunnel, you can have a widening, you can fracture, you can have problem with the right position, especially in revision cases. And then when you reduce it, you can get an insufficient reduction. You can also get an overcorrection. And when you drill the acromion tunnels, you should be aware of the bone density as shown by Distal. And as I said, revision cases, just like this one down here, anatomy may not be normal, so you have to compromise on tunnel placement. And also, sometimes you cannot restore the clavicle length. So in conclusion about AC joint reconstruction, the complication rate, even if we are moving forward, the complication rate is high. There's a high failure rate, in particular in the non-anatomic repair techniques. I think a high complication rate and high failure rate in majority techniques. I think it has something to do with the learning curve, and failure to address horizontal instability is a problem. We should have improved functions for the patient, better than nice x-rays. And I think it hasn't been proved, but free tendon graft for revision cases. We lack evidence for most of this, for the best initial treatment still. And also, even there are some studies now, we lack evidence for the best technique with the most successful outcome and the lowest complication rate. Thank you very much.